Imagine for a moment that you are a successful psychologist. A client named Cynthia comes to see you because she's having a problem. How do you treat her? How do you even know what's wrong with her? Now, clinical assessment is a way of diagnosing and planning treatment for a patient that involves evaluating someone in order to figure out what's wrong with them. Now, what's the point of assessment, you may ask? Well, to answer that, let's go back to the moment that Cynthia walks into your office. She tells you that she's feeling very stressed out and anxious because she keeps on forgetting things. She used to be really on top of things, but recently she's having trouble remembering where she parked her car or where she did or what she did just a few minutes ago. What's wrong with Cynthia? Well, there are many things that can cause memory loss. The only way that you can find out what's wrong with her is to do some sort of evaluation. Clinical assessments help you, the psychologist, to know what might be causing problem for your patient and to determine the best treatment plan for her. Now, in this video, we will look at an overview of the clinical assessment process. We will outline the range of assessment options available to the clinician, then describe the typical goals of assessment, that is diagnosis, description, treatment planning, and prediction. We will also talk about factors affecting a clinician's choice about how to conduct assessment. Later on, we will discuss the use of clinical judgment, focusing especially on errors that clinicians try to avoid. Lastly, we will talk about how to communicate to clients and third parties. So we conclude by discussing factors associated with reporting assessment results. Now, assessment involves a series of steps, beginning with a problem of referral that and ending with the psychologists communicating the result of the assessment to appropriate parties. In between, however, the clinician must make a number of judgments, such as which instrument to use and how best to convert clinical assessment data into clinical judgment. At each step, the clinical psychologist must engage in activities to ensure that the most relevant data are gathered and analyzed. Now, clinical assessment has been described in various ways, but all of them portray it as a process of gathering information to solve a problem. All of them recognizes that to be most effective, assessment activities should be organized in a sequence of systematic, logically related steps driven by a goal. Now, most assessments follow the general sequence outlined here, starting with receiving and clarifying the referral question, planning data collection procedures, collecting assessment data, processing data, and forming conclusions, and lastly, communicating assessment results. Now, two related questions must be answered before clinical assessments can be begin. What do we want to know? And how best can we find out about it? Now, answers to the first questions, what do we want to know, depend on who requests the assessment and for what purpose. The purpose or the person or agency requesting the psychological assessment is called the referral source. And the question or issue to be addressed in the assessment is called the referral question. Now, information that initiates an assessment is sometimes called the presenting problem, but we prefer to begin with the referral question because a specific question focuses on the assessment goals, while the presenting problem is often a long description of a client's difficulties. Now, the referral question is very important because it shapes the clinician's choice of assessment instrument and the interpretation and communication of results. Now, clinicians must therefore understand the context of the referral and often must help referral sources clarify the purpose of the assessment. Now, in doing so, clinicians may need to educate others about what a psychological assessment can and cannot reveal. They may also need to educate them about the clinical and ethical constraints involved in conducting assessment. Now, the referral question is the first step in shaping the ultimate goal of assessment. And generally, the clearer the goal, the clearer the question. As you can see here, referral questions can be quite varied depending on the referral source. Now, a parent can be a referral source, and the referral question a parent might ask is my child suffering from depression, and is she in need of counseling? Furthermore, a particular court can ask the referral question similar to this, like, is the respondent psychologically capable to comply with the fundamental marital obligations? Lastly, a client by themselves can uh, be the referral source, and they can have the referral question, what, if anything, should be done or should we do to salvage our marriage? Now, answers to the second question about how best we can find out what we need to know come into play after the referral question and the clinician's role have been clarified. With a clear goal in mind, the clinician can now begin planning methods to collect data. There is a vast range of data that might be collected about the client. To illustrate, consider the sheer number of things that can be asked about a person at several interrelated levels, from biological functioning to relationship with other people. Well, in fact, information used in case study guide includes but are not limited to the things that you can see here. Now, the enormous diversity of possible assessment data means that we can never learn all there is to know about the client. Of course, clinicians would typically seek more information about the client in categories that are more relevant to the assessment goals. Although the most important factors in the selection of assessment instruments is the referral question, other factors also affect the selection process. One of these is the quality of the assessment instrument or procedure. Obviously, clinicians would be better off selecting assessment methods whose psychometric properties, that is, reliability, validity, and usefulness, are the highest, but they might not always do so. For example, if one test had slightly lower but is still acceptable reliability than another, but provided more relevant information about a particular referral question, the clinician might select the one with slightly lesser reliability but greater relevance to assessment. Clinicians must consider too the characteristics of client when deciding an assessment or on assessment. Selecting instruments that are appropriate for each client in terms of reading level, length, and the like. Similarly, clinicians must explain to clients the procedures and purpose of the assessment using language that clients can understand. Now, to plan assessment, then the clinician must think broadly, weighing various features of assessment instruments against the practical consideration of time, context, and usefulness to clients and other referral sources. Now, the clinicians must also plan to combine and integrate the results of assessment into a narrative that serves a specific clinical purpose. Now, once the referral question has been clarified, the appropriate method has have been selected, and the client's cooperation has been secured, the data collection stage of assessment can begin. Now, clinical psychologists collect assessment data from four major sources: interviews, observation, tests, and historical records or case history. However, they seldom rely on a single assessment source to create a working image of a client. Instead, they use multiple assessment channels to cross-validate information about a wide variety of topics. Thus, hospital records may reveal that a patient has been there for 30 days, thus correcting the patient's self-report estimate of 2 days. Now, indeed, the whole story of a client's problem is seldom clear until multiple assessment sources are tapped. For example, people have been observed to be assertive in social situations, even though they describe themselves in an interview or a test as generally unassertive. It often takes multiple sources of assessment to separate those who do not engage in certain behaviors from those who cannot engage in them. Now, another benefit of using multiple sources is that appears when the clinician evaluates the effects of treatment. Suppose a couple enters therapy because of marital dispute, and then 3 months later, one of them filed for annulment. If the only outcome assessment employed in this case were marital happiness, as expressed during interviews, the treatment might be seen as having worsened marital distress. However, observations, third-party reports, and life records might show that one or both partners find their newly annulled status liberating and that they are developing new interests and abilities. Now, after assessment data have been collected, the clinician must determine what those data mean. If the information is to be useful in reaching the clinician's assessment goals, it must be transformed from raw form into interpretations and conclusions that address a referral question. Now, the processing task is formidable because it requires a mental leap from known data to what is assumed to be true on the basis of those data. In general, as the leap from data to assumptions get longer, inferences become more vulnerable to error. Now, consider this case. A young boy is sitting on a lawn cutting an earthworm in half. It would be easy to infer from this observational data that the child is cruel and aggressive and that he might become dangerous later on in life. These inferences would be off the mark, however, for what the observers could not see was what the boy, who happened to have few friends, thought as he cut the worm in half. He said to himself, "There, now you will have someone to play with." In short, elaborate inferences, especially when based on minimal data, can be dangerous. So, processing assessment data is difficult also because information from various sources must be integrated. Unfortunately, there are a few empirical guidelines for how to best combine data from interviews, tests, observations, and other sources to reach integrated conclusions. So, in forming their conclusions, clinicians often must rely heavily on clinical judgment, a topic which we will be talking about later on in more detail. Uh, in more detail. So, in forming their conclusions, clinicians often must rely heavily on clinical judgments. So, now the final stage in the assessment process is the creation of an organized presentation of results called assessment report. To be of greater value, assessment reports must be clearly written and clearly related to the goal that prompted the assessment in the first place. If the goal was to classify the client's behavior into a diagnostic category, information relevant to a diagnostic classification should be highlighted in the report. If assessment was aimed at determining a client's likely cooperativeness in and responsiveness to psychotherapy, the report should focus on those topics. Now, these simple, self-evident prescriptions are sometimes ignored in assessment reports, especially when assessment goals were never explicitly stated or when clinicians do not fully understand what their assessment instruments can and cannot reveal about the client. Now, assessment progresses in a series of steps that begin with with a referral question. Now, the referral question may come from a client, a third party, or the therapist, but the clinician must ensure that the question is clear and can be addressed reasonably by the available assessment instruments. Once the referral question is clarified, planning for assessment begins. Now, planning involves the selection of appropriate instruments, not a simple task given the number of factors affecting the clinician's choices. and preparation of the client. Now, data collection involves accumulating evidences from historical records, interviews, observations, and tests. Each of these sources has special strengths and limitations. In the data processing stage, the accumulated data are analyzed and integrated into a coherent assessment. Lastly, in the final stage, the clinician communicates conclusions and provide recommendations in ways that are clear and useful to the referral source. Now, let us look at the goals of clinical assessment, starting with diagnosis, followed by description, treatment planning, and prediction. So, as discussed in our first lesson, once clinical psychologists began working with adult clients during and after the First World War, they were often asked to perform clinical assessments for the purpose of diagnosing mental disorders in psychiatric patients. This process is variously called diagnostic classification, psychodiagnosis, differential diagnosis, or diagnostic labeling. APA defined psychodiagnosis as any procedures designed to discover the underlying factors that account for behavior, especially disordered behaviors. Today, diagnostic classification remain a significant part of a clinical research and practice. Now, accurate psychodiagnosis is important for several reasons. First, proper treatment decisions often depend on knowing what exactly is wrong with the client. Second, research into the causes of psychological disorders require reliable and valid identification of disorders and accurate differentiation uh, of disorders from another. Finally, classification allows clinicians to efficiently communicate with one another about disorders in a professional shorthand. Now, the use of a common nomenclature or naming system is extremely important in any field. Imagine, for example, how confusing it would be if medical patients would develop COVID-19 because of SARS-CoV-2 received a different diagnosis depending on which country they live in. Fortunately, if you have this, or unfortunately, if you have these conditions and are accurately assessed, you will be given the same diagnosis, that is COVID-19, whether you are in Manila, Tokyo, Nairobi, or Helsinki. That is because the World Health Organization International Classification of Diseases, or ICD, provide common codes that identify each disease. In clinical psychology and psychiatry, the comparable system is the American Psychiatric Association's Diagnostic and Statistical Manual of Mental Disorders, or what we normally call as DSM. So, as just noted, classifications should be reliable and valid and serve as an efficient shorthand for communication among clinicians and researchers. But for many clinicians, diagnostic labels are not enough. They want to know more, and consequently, diagnostic proposals often shade over into descriptive assessment, which these clinicians see as more important than diagnostic classification. Now, descriptive assessment by a cognitive behavior therapist, for instance, might focus on outlining factors such as an antecedent condition, environmental incentives, and disincentives. Um, Alternative sources of reward, cognitive complexity, attributional styles. Now, a psychodynamic therapist might focus on descriptive uh, assessments on ego strength and weaknesses, cognitive functioning, defense mechanism, quality of family and other relationships, and characteristics of the self. Of course, diagnostic classifications and descriptive assessments can go hand in hand. For instance, uh, Barthelesen in 1999 suggested that clinical assessment should work at two separate levels, one concerned with diagnostic classification, the other concerned with evaluating multiple factors that influence the course of treatment. Now, description-oriented assessment make it easier for clinicians to pay attention to clients' assets and adaptive functions, not just to the weaknesses and problems. Accordingly, descriptive assessment data are used to provide pre-treatment measures of clients' behaviors to guide treatment planning and to evaluate changes in behavior after treatment. Now, descriptive assessment can also improve measurement in clinical research. For example, in an investigation of the relative value of two treatments for depression, assessments that describe clients' post-treatment behaviors, that is absenteeism, self-reported sadness, and depression test scores, are of greater value than diagnostic labeling, that is of depressive versus non-depressive. Unfortunately, though, the movement towards broad descriptions of person may never dominate clinical assessment, especially in inpatient psychiatric setting and other managed care facilities. Now, the reason is time. As skyrocketing healthcare costs have increased economic pressures to limit hospital stays and to concentrate on focused assessment and short-term treatments, time-consuming and comprehensive patient evaluations are just too expensive. Now, the degree to which descriptive approaches to assessment gain widespread uses will ultimately depend on their empirically demonstrated usefulness. The degree to which clinicians can perform assessment effectively and use them to design better research and treatment. Now, diagnostic and descriptive assessment can be used to plan treatments. In the simplest model, a diagnosis, for example, depression, leads to a preferred treatment that is, for example, cognitive behavioral psychotherapy. Just as a given medical illness that is, for example, strep throat or sore throat might lead to a preferred treatment that is antibiotic. Identifying ideal connections between diagnosis and psychotherapy methods has been a main goal of the empirically supported treatments movement. While efforts to match specific treatment with specific diagnosis have certainly improved the empirical base of psychotherapy, the enterprise has not worked out as clearly or rather as cleanly in practice as many had hoped for. As the previous discussion on diagnosis implies, diagnostic classification is imprecise. And it is difficult to argue that specific treatments work for specific diagnoses when the diagnoses themselves keep changing. Furthermore, extensive research on psychotherapy effectiveness show that treatments often have general and overlapping effects, some of which have more to do with characteristics of the person involved than with disorders to which they are applied. So because of these problems, clinicians have sought to incorporate other factors into treatment-related assessment. The key is to identify which factor, apart from the diagnosis and the brand of psychotherapy, best predict how an intervention will work. In short, treatment planning assessment goes beyond the basic medical model question. That is, which treatment works best for which diagnosis. Instead, it addresses the more detailed question famously stated by Gordon Paul in 1967, that is, what treatment by whom is most effective for this individual with that specific problem and under which set of circumstances. Now, treatment-related assessment can also focus on the questions of how well treatment has worked. Indeed, clinicians working on today's accountability-driven climate are increasingly asked to provide evidence of their effectiveness. Generating that evidence require assessment, and there are many ways to assess the results of treatment. Questionnaires, client self-report, tests, and a variety of other measures can be used to evaluate treatment programs. For most clinicians, however, the goal is to record outcomes quickly, efficiently, and accurately, and to periodically review the data to assess their treatment strength and weaknesses. Having this outcomes data is essential even without the pressure applied by third-party payers because consensus self-assessment is part of the of the professionalism normally expected of clinical psychologists and indeed of all healthcare providers. Now, assessments can also be used as an explicit component of treatment. There is substantial evidence that discussing assessment methods and results with clients can have greater therapeutic value. Greater involvement in assessment might encourage her or him to be more objective and accurate in her self-monitoring. It might increase their trust in the therapist and in the treatment. It can provide them with another avenue of therapeutic interaction. Assessment expertise is a traditional strength of clinical psychologists, and so it makes sense to use this strength to therapeutic advantage. Now, a final goal of clinical assessment is to make predictions about human behavior. Such predictions might include forecasts about how the symptoms of a client's disorder might change with or without treatment. That is called prognosis, which we will be talking about later on, but about future performance or descriptions of how someone will perform in a given job or situation, or about dangerousness, descriptions of the likelihood of someone behaving violently towards self or others. In any of these predictions, clinicians must have valid information about how the characteristics uh, revealed by assessment relate to the behavior being predicted. Without that link, predictions would be little more than guesswork. Most often, prognosis refer to a prediction about the outcome of treatment, but it can also refer more generally to predictions about changes in symptoms without treatment or under certain circumstances. For example, a head injury might change the prognosis for treatment of an anxiety disorder. Now, DSM diagnosis already contain considerable information about prognosis, including the result of long-term studies of the course of a disorder, as well as other information related to its typical onset, chronicity, those most at risk, and the like. And although the DSM does not provide specific prognosis statement, it is not difficult for clinicians and even students to recognize that some disorders tend to be more debilitating than others, more chronic or more prone to relapse, or more responsive to treatment or to a certain positive or negative life circumstances. So, clinicians can build upon the basic information in the DSM to provide their prognosis. For example, information about the client's level of social support and subjective distress can alter a prognosis. Relatively high levels of social support and moderate but not debilitating distress improves prognosis, whereas relatively low level of support and intense distress worsen them. Prognosis can also be influenced by such client factors as impulsivity and coping style, resistance to therapist suggestions, treatment setting, that is inpatient versus outpatient, the fit between client and therapist, for example, shared values or cultural background, and the client's belief about treatment. Now, the degree to which a prognosis should be adjusted by these or other factors should be guided by empirical research, evidence about the degree to which each factor has been shown to influence treatment outcomes in similar cases. Now, a final goal of clinical assessment is to make predictions about human behavior. And these predictions are most oftenly related to prognosis. Now, the mass media have long cast clinical psychologists as experts who can astutely translate obscure signs into accurate statements about a person's past, present, or future. As in the case of violence, some events are particularly difficult to predict. But whether a clinician is trying to judge the likelihood of a client attempting suicide, a stalker harming a victim, a child being abused by a parent, a brain injured client succeeding in a new job, or a particular form of psychotherapy alleviating a sufferer's anxiety, all predictions involve clinical judgment. The truth is, empirical research does not support the idea that clinicians have special inferential capabilities. The idea that clinicians have or can develop some special kind of antenna with which they can detect otherwise subliminal interpersonal stimuli and read from these the intra-psychic conditions of another person is a myth which ought to be demolished. There is now a large body of research which has addressed the accuracy of clinical intuition by comparing clinical judgments with judgments made by laypersons or with judgments based on statistical or mechanical models. The clear result is that the clinical intuition is too often that clinical intuition too often underperforms. Now, the question is, why do clinicians not make better judgments, even after years of training and experience? Well, apparently, being humans, clinicians are prone to the same cognitive habits and biases that can lead to error in anyone's information processing. For example, clinicians' judgment, like other humans' judgments, are more prone to error when they rely too heavily on experience that are recent or remarkable enough to make them especially available to recall. The bias created by this availability heuristic can be seen, for example, when people are asked to judge which of the following is more common. Either seven-letter English word ending in ing or seven-letter English words with n in the sixth position. Now, people often choose the first option simply because ing words are much easier to bring to mind than words with n in the sixth position, but in fact, words in the latter category are more common. They include all ing words as well as all seven-letter words that end in NT, for example, payment or NE, biplane, and so on. Now, consider the tragic and highly publicized mass shooting that took place in around 2012 at an Aurora, Colorado movie theater and the Sandy Hook Elementary School in Connecticut. Now, shocking incidents like these considerably lead people to think that multiple murders are quite common. Well, the truth is, though it's um though there have been 62 mass shootings since 1983 in the United States, individual murders are actually far more frequent. Um, an FBI figure shows that 8,583 people were shot to death in 2011 alone. Nevertheless, judgments about the probability of vivid, highly memorable events can easily become inflated in the minds of the public, clinicians included. So, in clinical situations, then a psychologist may overemphasize the likelihood of diagnosis that come most easily to mind and thus misdiagnose. Now, memorable clinical folklore can create illusory correlations, causing clinicians to draw false inferences from assessment data. Thus, some clinicians see paranoid tendencies in clients who draw large eyes on figure drawing tests, even though there is no firm empirical evidence to support this association. Like the first impressions, the first impressions all people form, clinicians also tend to display an anchoring bias in which they establish their views of a client more on the basis of the first few pieces of assessment information than on any subsequent information that is. Anchoring bias can also influence clinicians to let assessment information coming from certain sources, that is, from parents, report of a child's behavior, outweigh any other information they receive. The problem with anchoring bias is that we hold too firmly to first impressions and do not make sufficient adjustments when new data warrants doing so. If anchoring bias combines with confirmation bias, the tendency or confirmation bias is the tendency to interpret the information in line with existing belief, the clinicians or the clinician may ignore contradictory evidences, discounting its validity, or even distort it to fit the initial impression. Now, numerous studies also suggests that having large amounts of assessment information may increase clinicians' confidence about their inferences, but it does not necessarily improve the accuracy of those inferences. So that's because additional pieces of information can contribute to additional error. The less precise the prediction, the greater the error contributed. Clinicians' judgments may also be prone to error because they misremember information or fail to, to get important information. Like other people, clinicians tend to remember their successes more clearly than their failures, and so may remember uh, or so they remain wedded to incorrect inference tendencies or invalid assessment methods simply because they think of them as valid. Indeed, clinicians may not get enough accurate feedback about their successes and failures. Now, in 1972, Thorne suggested that clinicians must become much more critical of the types of judgments they attempt to make, the selection of cues upon which judgments are based, and their modes of collecting and combining data. If you think about it, that statement still applies today. And based on years of research on the issues of statistical versus clinical predictions, the following conclusions seem to be reasonable. Number one is that statistical or actuarial predictions generally outperforms clinical predictions. Number two is that the superiority of statistical prediction is most evident in predicting violence and other low-based rate events. Number three is that the overall advantage of statistical prediction is modest, and occasionally clinical prediction does as well or significantly better, though not in any particular pattern of circumstances. And number three, predicting or practicing clinicians typically underutilize and undervalue actuarial predictions or statistical prediction methods. So the question is, how do we improve clinical judgments? So the thing is, clinicians find it discouraging that their inferences, honed by training and experience, are often inferior to mechanical decisions that can be arrived at by anyone who can read and has the relevant assessment data to plug into a formula. Yet, if one takes a broader view, the generally superior performance of of statistical models, particularly for low base rate events such as violence, need not be seen as a sign of professional failure. A great deal of clinical experience and research typically goes into the development of useful statistical models. We have always relied, which we have always relied on research to separate the wheat from the chaff in clinicians' favored theories. Furthermore, we don't denigrate meteorologists or stockbrokers when they rely on statistical models and computer-generated forecasting. Nor do we distrust physicians who refer to uh, databases and formal decision models to help them diagnose unusual medical conditions. Indeed, though, some people are willing to accept intuitively from the hip judgments from a doctor. We suspect the most I suspect that most appreciate the thoroughness and professionalism of a physician who take advantage of the latest research and technology in reaching a diagnosis. At the same time, it's important to recognize that clinical experience and judgment are not invariably error prone. With more years of experience, clinicians' judgments tend to improve, though modestly at best. Spengler in 2009 conducted a meta-analysis of 75 judgment studies involving 4,607 clinicians and found that the accuracy increased by about 13% with experience, regardless of other factors, that is. Just how experience improved judgment is not entirely clear. We suspect or rather, it has been suspected that it's not merely the repeated use of clinical intuition, but rather the repeated use of intuition combined with timely feedback about the accuracy of predictions. Now, more experience may also be associated with more time to learn about research findings on clinical decision processes, including the numerous factors that can bias clinical judgments, which in turn may make clinicians less vulnerable to those factors. Now, now, this highlights the importance of the fact that clinician or clinical psychologists should be familiar with the extensive research literature on clinical judgments and on clinical versus statistical predictions, and that they should be guided by it. So now let's move on to psychometric properties and assessments of assessment instruments. Now, sound clinical judgments depend on the soundness of the measure used to help make those judgments. Assessment instruments of higher quality are those that carefully conducted research has shown to be reliable, valid, and useful. So in this part of the lesson, we consider the dimensions that determine an instrument psychometric quality. So when we say reliability, it means or reliability refers to consistency in measurement or to agreement among different judges or raters. Validity, on the other hand, uh, reflects the degree to which a particular tool or measurement measures what it's supposed to measure. Um, Standardization, on the other hand, or rather, when we say that a test or other assessment instrument is standardized, we mean that the designers of the scales have given it to a large representative sample of persons and analyzed the scores. Lastly, uh, clinicians or clinicians' assessment choices are further guided by their attempts to resolve the bandwidth fidelity dilemma. So just as greater bandwidth is associated with lower fidelity in broadcasting, clinicians have found that given limited time and resources, the more extensive they explore a client's behavior, the less intensive each aspect of the exploration becomes, and well, vice versa. The breadth of an assessment device is thus referred to as its bandwidth, and the depth or exhaustiveness of the device is its fidelity. Now, this issue is also called the depth breadth issue. If during a 2-hour interview, for example, a clinician tries to cover a long list of questions, the result would be superficial information about a wide range of topics. This means broad bandwidth that has low fidelity. If the time is spent exploring the client's early childhood memories, the result would be a lot of detailed information about only one part of the client's. This means it has narrow bandwidth yet with high fidelity. Accordingly, clinicians must seek assessment strategies and measurement tools that result in an optimum balance between bandwidth and fidelity. The questions, levels of inquiry, and assessment techniques that will be used in identifying stress resistant executives differ substantially from those that will help detect brain damage in a 4-year-old child. Lastly, let's talk about communicating or the criteria for communicating assessment results. Now, if assessment results are to have maximum value, they must be presented in reports that are clear, relevant to the assessment goals, and useful to the intended consumers. Accordingly, clinicians must guard against problems that can make report vague, irrelevant, and useless. In the last part of the lesson, we will talk about the criteria for an assessment report. The first criterion for an assessment report is clarity. Without this basic attribute, relevance and usefulness cannot be evaluated. Lack of clarity in psychological report is troublesome because misinterpretation of a report can lead to misguided decision. Now, although far less common today than in the past, clinicians may still be asked for psychologicals, usually a standard test battery or an interviews, without being told why assessment is being done. Under such circumstances, the chances of writing a relevant report are minimal. Unfortunately, there are other cases in which a report's lack of relevance is due mainly to the clinician's failure to establish assessment objective in mind. That is why relevance to goal is yet another uh, criterion for communicating assessment results. Finally, one must ask if an assessment report is useful. Does the information it contains add anything important to what we already know about the client? Reports that present clear, relevant information that is already available through other sources may appear useful but have little real value. Such reports tend to be written when the assessor has either failed to collect new information or has not made useful statements about the data or about new data, that is. In the former case, the clinician may have employed techniques that have low incremental validity. For example, a clinician may use psychological tests to conclude that a client has strong hostile tendencies. But if police reports show that the client repeatedly has been arrested for assault, this conclusion does not add much to the clinical picture. In other instances, the assessor's report may have limited usefulness because it says nothing beyond what would be expected on the basis of base rate information, past experiences, and common sense. So this ends our lesson on the basic features of clinical assessment. Okay, my name is Dex Kamitan and thank you for watching.